Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing about benign salivary gland tumors. We'll talk about the incidence of these tumors, what is the classification of these tumors, which gland is it more common in, which glands are more commonly malignant tumors. And other than that, we'll also talk about what are the clinical features, how do you investigate such a case, and how do you treat these cases. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. So, benign tumors of the salivary gland. Looking at the bigger salivary, the major salivary glands, in case of parotid, the benign parotid neoplasms have an incidence of about 5.3 to 6.2 per 1 lakh population. Whereas for submandibular gland, the same number is about zero point 0.5 to 0.55 per 1 lakh population. So, what we get from here is that parotid gland is the more common gland which is involved in case of benign salivary gland tumors. After that would be the submandibular gland. Now we know there are major salivary glands and minor salivary glands. The ones that we know are parotid, submandibular, sublingual, and the minor salivary glands. So according to site, let's also look at which glands tend to be more involved in cases of benign tumors and which glands are more involved in malignant tumors. This is a very important MCQ question and even a Viva question that you may be getting. So first, let's look at parotid. So we can see that in case of parotid, 80% of the tumors are benign tumors, whereas 20% are malignant. In case of submandibular, we see that 60% is benign and 40% is malignant. And in case of sublingual and minor salivary glands, we see the case is actually the opposite to that of parotid. The 10% of it is benign, whereas 90% of it is malignant. So, what are we seeing here? So, the biggest gland over here is the parotid, then the submandibular, and then the sublingual and minor salivary gland. So, as the gland goes smaller, we can see that the malignancy also starts to increase. So we can see parotid is the largest gland over here. The chances of malignant tumor in this case is the lowest. Whereas we can see that the minor salivary glands and sublingual glands are the smallest glands, salivary glands over here, and the chances of malignancy is the highest in these cases. So what conclusion do we draw from here? That smaller the salivary gland, higher would be the chances of malignancy. Next, let's talk about the different salivary glands and what percentage of all salivary gland tumors is seen in each of these glands. So, as I mentioned before, the most common gland to be involved in cases of tumor is parotid gland. So, 80% of the salivary neoplasms, of all salivary neoplasms, is involved at the parotid gland. This is again an important MCQ question. Out of these neoplasms, 80% of this is benign. So we already saw above that parotid gland, in case of parotid gland, 80% are benign and 20% of malignant. Now, out of these 80%, which is benign, the most common benign salivary gland tumor in case of parotid is pleomorphic adenoma. This is also an MCQ question. And what is the most common site of pleomorphic adenoma? 80% of it is seen in the superficial lobe. So these are 4 MCQ questions right over here. Next is 15% of the salivary gland tumors are seen to be happening in the submandibular gland. Now, out of this, about 50 to 60% would be benign. So, as you see the size reduction happening here, we can see that the percentage of benign tumors has gone down. And out of these 50 to 60%, which is benign, we see that 95% of it is pleomorphic adenoma. So the most common tumor over here is also pleomorphic adenoma. Next, 5% of the salivary glands involve the minor salivary glands. Now, these minor salivary glands can be in the lips, palate, cheek, etc. And out of which only 10% are benign. So, this is important over here. We know that 90% of minor salivary gland tumors are actually malignant. So, that would be a cause of worry if you see a patient who has a tumor of the minor salivary gland. Whereas if a patient comes to you with a tumor of parotid gland, more chances of it being benign rather than malignant. So that's all about the incidence of the different tumors. Now, coming to age and gender prevalence, in case of all salivary gland tumors, the most common age group affected is the fourth to sixth decade, with a peak in and about the sixth decade. And another very important MCQ question is salivary gland tumors are more commonly seen in females. So, this has a female preponderance, except for one benign salivary gland tumor, which is Warthin's tumor. Warthin's tumor is the only salivary gland tumor which is more commonly seen in males. So, this is an important MCQ and a Viva question for you to remember. Now, let's talk about the etiology of benign salivary gland tumors. What are the possible causes behind this? First of all, radiation exposure. Now, radiation exposure is more associated with malignant tumors, but there has been some association, and where we have seen that a prior head and neck irradiation has been seen to be a risk factor, especially in case of Warthin's tumor. Secondly, where does this irradiation happen from? So, this can be either therapeutic radiation, for example, treatment for childhood cancers, or occupational radiation exposure as well. Both have been linked to developing benign salivary gland tumors. Next is smoking. Again, smoking has also been strongly associated with Warthin's tumor. Third point is viral infections. In amongst all viral infection, HPV-16 has been seen to be more commonly associated with benign salivary gland tumors. Next is hormonal and gender influence. We have seen that all salivary gland tumors have a female preponderance. So there must be some kind of reason behind that. It has been seen that estrogen and progesterone receptors, these may be playing a role because benign tumors have been seen to be more common in females. And lastly, maybe there is some environmental and occupational exposure, like workers who are exposed to rubber, asbestos, plumbing, even woodworking industries, they have been shown to have a higher incidence. And chronic irritation or trauma is sometimes suspected, but this association has not been strongly proven. So, these are all the various factors that could be a causative agent in causing a benign salivary gland tumor. Now that we know that, let's move on to discussing what are the clinical features. So we'll discuss about the different glands, how it will present. But before that, it is important to know that most of the times, whether it's parotid or the submandibular gland tumors, they actually do not cause any symptom. They can just present with just a very small swelling which is growing very slowly over a long period of time. So it is not necessary that you will be seeing a symptom in your patient. Sometimes when there is symptom, there can be discomfort due to obstruction of the salivary flow. So if there is any obstruction to the salivary flow of the salivary glands, in that case, a patient may come to you with some discomfort. So usually the patient will have a swelling which is smooth, relatively very mobile, and painless to palpate. So these are very important feature. If there is no pain, you do not suspect any kind of malignancy. This is a telltale feature of benign salivary gland tumor. And also secondly, they are very mobile. So these are the general features of a salivary gland tumor. Now say a parotid tumor case comes to you. So if you look in the image over here, we can see that we are seeing a firm swelling behind the angle of the jaw or near the angle of the jaw. This is the region where it comes in. So it can either be in the retromandibular region, or it can be in front, even in front of the tragus or at the cheek if it starts getting bigger. So these tumors usually they grow very slowly over a long period of time. So we know that parotid gland has a superficial lobe and a deep lobe. For knowing more of the anatomy, I have a separate video on it. You can check it out over there. So, in case most of the times we have seen 80% cases on pleomorphic adenoma, for example, superficial lobe is involved. However, there are also tumors which can originate from the deep lobe of the parotid gland. When that happens, this deep lobe parotid tumor can end up displacing the tonsil medially, and they can often not turn out to be like the swelling that we are seeing over here. You can actually end up seeing an intraoral swelling. If you see here, we do not have an image over here. This first image, however, you can see that if the deep lobe is involved, it can actually present as an intraoral swelling rather than an extraoral swelling. So that is how a deep lobe parotid tumor would present. And if there is a very large parapharyngeal salivary tumor, it can end up causing stutter, sleep disordered breathing, and affect the quality of patient's voice as well. And in major cases, can even interfere with eustachian tube function. So this is how a parotid tumor usually present. If the deep lobe is involved, you have to look inside the oral cavity as well. Only external examination will not be enough. Next, submandibular tumor. Now, if we look at the image right over here, this is a submandibular gland tumor. So, usually we see a swelling in the submandibular triangle, and this swelling can be bimanually palpated. How do you differentiate a submandibular gland swelling from a submandibular lymph node swelling? The key is to bimanually palpate it. If it's involving the submandibular gland, you will be able to palpate it. But if it's a nodal swelling, in that case, you will not be able to palpate it bimanually. And sometimes it can be very difficult to differentiate a tumor arising from the posterior aspect of the submandibular gland from one that is arising from the tail of the parotid. So that's about the submandibular tumor. Lastly, any minor salivary gland tumor usually presents as a firm submucosal swelling. You can see in this image and the palate over here, the palate is actually the most common site of involvement in case of minor salivary gland tumors. So you see a submucosal swelling over here, and very rarely this swelling can have ulceration unless ulceration will be happening in case there is local trauma in that region, but usually it is not seen. So it presents with this kind of a swelling. So that's all about the presenting features of the different salivary gland tumors. Now, how do you suspect that a benign tumor has undergone malignant transformation? There are certain red flag signs that you should be looking forward to, certain complaints or certain clinical features, certain signs. So, first of all, any patient of salivary gland tumor who is complaining of pain, that is suggestive of malignant transformation. Other than that, other red flag signs here would be paresthesia, rapid growth or any increase in rate of growth, facial nerve palsy or any other nerve palsy depending on the uh, salivary gland involved. If there is skin involvement, that is also indicative of malignant transformation. The tumor can be fixed, or if you find irregularity. So these are all the features that you will be seeing, and these are all red flag signs which are suggestive of malignant transformation. So that's about the clinical features. Now let's talk about the classification. So the WHO classification of benign salivary gland tumors divides it into two types: epithelial tumors and mesenchymal tumors. So epithelial tumors are the more common tumors. Amongst epithelial tumor, the most common one is pleomorphic adenoma, and the second most common one is Warthin's tumor. I will be discussing these two tumors separately in separate classes, so we'll not be talking about them today. But I'll talk about the rest of them. So, other epithelial tumors, the less common ones, involve oncocytoma, which is also known as oxyphil adenoma, myoepithelioma, which arises from myoepithelial cells, basal cell adenoma, canalicular adenoma, and other ductal adenomas, and sebaceous adenoma. These are all the epithelial tumors which can be found. Coming to mesenchymal tumors, which are less common, less known, more common amongst them would be hemangioma and lymphangioma, and rarer types would be lipoma, neurofibroma, chondroma, osteoma, and schwannoma. So, this is the WHO classification of the benign salivary gland tumors. Now, let's talk about some features about each of these tumors that I have mentioned here. After that, we'll be discussing the investigation and treatment. So, first of all, is oncocytoma. So, oncocytoma is a rarer tumor. about less than 1% of all salivary tumors. As I said, it is also known as oxyphil adenoma. Where does it originate from? It originates from these acidophilic cells, which are known as oncocytes. That's why this is known as oncocytoma. Here, the age is little higher than the usual. So it is seen in the elderly in about the 7th to 8th decade. As usual, this has a female preponderance. The most common site of involvement is the superficial lobe of parotid. Causes over here is radiation on uneven occupational hazard. Just like any other benign tumor, it is also slow growing and rarely bilateral. And when you perform histology, on gross examination, we will see a small tan colored, well circumscribed, and encapsulated solid tumor. So, these tumors have a capsule in them. On microscopy, we notice large oncocytes with swollen granular cytoplasm. And this is the swollen granular cytoplasm is because of abundant mitochondria. And another important feature over here is we see tyrosine crystals present in the glandular spaces. So these oncocytoma, these tumors, they are cystic rather than solid. And another important feature over here, which can be an MCQ question, is they have an increased uptake of technetium 99M. So that is an important investigation to remember for oncocytoma. How do you treat it? If it involves, mostly it involves the parotid. So in that case, you do a superficial parotidectomy. And this has very less chances of recurrence. But if recurrence does happen, it will be because of other nodules of tumor tissue within the gland. So that's about oncocytoma. Next is myoepithelioma. As the name suggests, myoepithelioma arises from myoepithelial cells. This is a very rare tumor. So at one point, it was considered to be a variant of pleomorphic adenoma because in pleomorphic adenoma, myoepithelial cells are also involved. These tumors are seen in both children as well as elderly, and there is no sex predominance over here. And there is also no predominance of salivary glands. All of the salivary glands can be affected. There is no other distinct clinical characteristics. And in case of treatment, we treat it the same way as we will treat pleomorphic adenoma. Next tumor is basal cell adenoma. Again, this is a very rare epithelial tumor. This is common more in the minor salivary glands. But if the major salivary glands are involved, in that case, they will be multicentric. On gross examination, they will look like lymph node. And on microscopic examination, we will see isomorphic basaloid cells with solid or trabecular or tubular or even membranous pattern. That's about basal cell adenoma. Now it has been considered to be under monomorphic adenomas. Classification has changed under this. Next is canalicular adenoma. Now, canalicular adenoma is a variant of basal cell adenoma, which is differentiated from it by bilayered ribbons of columnar cells separated by vascular stroma. So, that's about canalicular adenoma. Next, let's talk about some of the mesenchymal tumors. So, the most common mesenchymal tumor here would be hemangioma. Another important MCQ related to this is that hemangioma is actually the most common benign tumor of parotid that occurs in cases of children. In cases of adults, it is pleomorphic adenoma. So, in terms of age, as I just said, it occurs in children. So, most of the time, these are discovered right at birth and they grow very rapidly in the neonatal period. And then they also involute spontaneously. So, most of the time, they do not require any treatment. There is a female preponderance over here. And how will it present to you? They'll come with a soft, painless swelling which increases in size as the baby cries or any kind of straining is done. Overlying skin may show a bluish discoloration, and cutaneous hemangioma may coexist in about 50% patients. How do we manage this? Most of the time, we do not need to do anything. It regresses spontaneously. But in case it has not regressed spontaneously, in that case, surgical excision is the treatment of choice. Last of all is lymphangioma. Now, lymphangioma is a lesser common mesenchymal tumor. This can involve the parotid as well as submandibular gland, and on palpation, you'll find it to be very soft and cystic. Unlike hemangioma, they do not regress spontaneously. They will definitely need surgical excision as treatment. So that's all about the different types of benign salivary gland tumors. I will be talking about pleomorphic adenoma and Warthin's tumor in separate videos. Now we'll talk about how do we investigate any case of benign salivary gland tumor. So our first line of imaging over here, first of all, before we do any kind of biopsy or any kind of tissue sampling, first we have to do imaging. So our first line imaging over here is an ultrasound. This ultrasound will help us in differentiating whether the lesion is solid or cystic or whether it is intra or extraglandular lesion. And ultrasound is sometimes often used in guiding FNSC as well. That actually improves the accuracy of the FNSC done. There are some scenarios where we do perform CT scan or an MRI. Amongst these both, MRI is actually the gold standard for in cases of soft tissue delineation. Now, in which cases will we do a CT scan or the MRI? Usually, we do not do it as a routine for all benign cases. So, in the indications over here would be first of all, if the tumor is very large, meaning more than 3 centimeter. Second, if we see that there is a deep lobe or a parapharyngeal space involvement. In that case, sometimes what happens is ultrasound can actually end up missing dumbbell-shaped tumor. Now, dumbbell-shaped tumor is actually very characteristic of parotid tumor where there is deep lobe involvement. So, in this case, greater part of the tumor lies in the parapharyngeal space. So, USG may not be very sensitive in detecting these cases. And third indication is whenever whenever we are suspicious of any malignancy. In these cases, we should perform a CT scan or an MRI. When you perform an MRI, benign lesions look well circumscribed, homogeneous, and T2 hyperintense. These are the two things about imaging. Now let's move on to the next part. Next important diagnostic tool is the fine needle aspiration cytology. This will help in differentiating benign as well as malignant, and it has about a 90% accuracy. And we can increase in accuracy by clubbing it with USG. So we do a USG guided FNSC. Second is core needle biopsy. Now, usually we do not do core needle biopsy. We reserve it in case the FNSC has come out to be conclusive. Why is it not done? Because this has higher risk of complications than FNSC. Here, you can easily lead to tumor seeding or facial nerve injury. So, usually this is not performed. Next is scalography. Again, this is, I'm just saying for you to know what used to be done earlier, but this is not done nowadays. This has been replaced by ultrasound as well as MRI. Earlier, it used to be done to outline duct system. So, if you did do scalography for a benign tumor, you will be seeing some filling defects in the duct system. Last of all is scintigraphy, where we use technetium 99M pertechnate. This is very useful for Warthin's tumor because in this case we see hot spot in case of Warthin's tumor because of high mitochondrial activity. So these are all the investigations that we will be performing in case of a benign salivary gland tumor. Now, how do we treat them? So, in case of treatment, there is no doubt over here, there is no role of any other treatment. The treatment of choice is to perform surgery. There is no role of radiotherapy or chemotherapy in case of benign tumors. Our aim of surgery over here is to completely excise the tumor and try to preserve nerves. In case of parotid, it is facial nerve. In case of submandibular, it is hypoglossal nerve or the lingual nerve and the marginal mandibular nerve. And second aim is to give adequate cosmetic and functional outcome to the patient. So there are certain factors which affect the treatment choice that you make. What are these factors? There are 4 such factors. First of all is the site of tumor, meaning which salivary gland has it involved. Is it involving the parotid or the submandibular, the sublingual or the minor salivary gland? So in each of these cases, the surgery would be very different from each other. Second is the size and extent of the tumor. If it has involved the parotid, has it involved the superficial lobe or has it also involved the deep lobe? The treatment will differ in that case. Third is the histological type, meaning is it a pleomorphic adenoma or Warthin's tumor or any other tumors? And last of all is patient factors, which can be the age of the patient, the comorbidity of the patient, any cosmetic concerns. So these are all the factors which affect the treatment choice. Now let's discuss according to the site of the tumor, what is the treatment of choice that we would go with. So, in case of parotid tumors, there are two types of treatment over here. First is a superficial parotidectomy. As it suggests, it means that we are removing the superficial lobe of the parotid gland. So, in case the tumor has only involved the superficial lobe, we remove the tumor along with the superficial lobe of parotid gland and we preserve the facial nerve. Here, we do not take out the deep lobe. Second surgery is a total conservative parotidectomy, which means in any case we see that the tumor has involved the deep lobe of the parotid as well. In that case, we remove both the lobes along with the tumor, but it is named conservative because we try to preserve the facial nerve. We are not removing the facial nerve over here. So, the first indication over here is when the tumor has involved the deep lobe of the parotid. And second indication is if there is any spillage of tumor during the time of superficial parotidectomy. In that case, also we will perform a total conservative parotidectomy. So this was about parotid tumor treatments. Next is submandibular gland. So if the submandibular gland is involved in a benign tumor, the only answer over here is a total excision of the gland along with tumor. We do not do a partial excision of the gland here, we remove it completely. And if you are suspicious, you can even sample the adjacent lymph nodes. That's about submandibular gland tumors. In case of sublingual gland tumors, we'll also excise the gland along with the tumor and we'll do it via the intraoral approach. And lastly, for minor salivary gland tumors, depending on what it involves, we'll perform a wide local excision with a margin of normal tissue. The most common site amongst this is the palate. So if we find a palatal tumor, we will perform a wide local excision down to the periosteum. And after that, we have to do a local fab reconstruction. So that's all about the treatment and investigation in case of a benign salivary gland tumor. In my next class, I will be talking about pleomorphic adenoma and every detail regarding it. See you in my next class. Thank you.